introduction, and I can't believe how many years ago it is since you were here, and we desperately tried to keep you, but you went back to greener pastures in your home country. So it's my absolute pleasure to be able to join you this afternoon to talk about the long-term effects of child sexual abuse. And what I'd like to do before I begin is just provide a little bit of background with what I consider my connections to Scotland. So I'm from originally Calgary in Canada, and people may or may not know that Calgary is a city which was originally a fort established by the Northwest Mounted Police in the 1870s, really to prevent the whiskey trade between American frontiersmen and the Aboriginal people in Canada. And the first commissioner of the Royal Canadian, or what was then the Northwest Mounted Police, was Colonel James MacLeod, who was born in the Isle of Skye in Scotland, and trained as a lawyer and became commissioner of the police force. And the Calgary, where I grew up, was originally called Fort Brisbois, named after one of the officers in the police force. But the story, whether it's apocryphal or not, who knows, is that Colonel MacLeod returned to Scotland. He visited the Isle of Mull and Calgary Castle, which is this castle. Here I realize there are many, many castles in Scotland, but this is one that he took fancy to. He stayed there with his wife and returned to Canada and named Calgary after this location in Scotland. So now, of course, Calgary is quite a large city, and this is still a small village, a very quaint village in Scotland. So I feel like I have some connection from birth to Scotland. Also, I enjoy whiskey, so that's another affinity to Scotland. Now, my story begins in a strange sort of way. So I've spent most of my life as a clinical forensic psychologist and lawyer, working primarily in forensic mental health and correctional mental health for about 35 years or so. But I actually began life as a young psychologist with a great interest in children. And I worked at this hospital called the Alberta Children's Hospital. This is an old picture. I wasn't working at that time. This was in the 1960s. And I was attending the University of Calgary. And this, in fact, did happen while I was there. Engineering students managed to hoist this Honda Accord on this archway that's an entrance to the university. And while I was studying and training at the Children's Hospital, I was appointed to work in the child abuse unit. And my role was to work with young children who were abused, including sexually abused. And I spent about 2 years there doing that work. And I moved from the Children's Hospital to work with young offenders, and then graduated from working with young offenders in 1984 to working with adult offenders and forensic patients in a secure hospital setting. So it's very interesting that although most of my work has been in the offending area, I've come full circle in the last 15 or so years with respect to the interest in child abuse. So what I want to do this afternoon is speak about what we know about really the long-term effects of child abuse. And I want to end the discussion by talking a bit about some policy implications and suggestions. And as Lindsay mentioned, we certainly welcome dialogue on the chat, and we'll turn to that at the end of the presentation. Now, I owe a great deal of gratitude to a whole host of colleagues, most significant of whom is Emeritus Professor Paul Mullen. Many people will know Professor Mullen by his reputation. He was the foundation professor of forensic psychiatry in Victoria and established the Victorian Institute of Forensic Mental Health. And he has long-standing expertise and interest in child abuse that extends long beyond his time in Victoria. And over the 15 or 20 years, a host of different colleagues with whom we work. Most notably now, Dr. Nina Papalia, who's really flying the flag in this research space, but a host of other colleagues who assist and assist us in the work. Now, as most people will know with backgrounds in mental health and psychiatry, there's been a roller coaster sort of relationship between child sexual abuse and the extent to which children are essentially believed. So interesting enough, when I entered the workforce, it had not been very long before children were generally not believed when they expressed or when they voice issues pertaining their own victimization and abuse. And this is just an indication from not so long ago, if you think about time, about how skeptical the law was about people who were abused, both women and children. And this is a very noted American law professor, Wigmore, whose books on evidence are still used in law teaching in the United States. And so he talked about modern psychiatrists have amply studied the behavior of errant young girls and women coming before the courts. Their psychic complexes are multifarious, distorted partly by inherited defects, partly by diseased arrangements or abnormal instincts, partly by bad social environments, partly by temporary physiological or emotional conditions. One form taken by these complexes is that of contriving false charges of sexual offenses by men. And certainly, right up until the early 1960s, and probably there are a variety of reasons for this, including Freud, but also some other issues that have arisen. So this is in fact an area that has suffered greatly over many years about the extent to which children are believed. I think we have turned the corner now, and I'm not sure that people there would be aware, but in Australia we had a very significant Royal Commission on the institutional abuse of children, and this had a very profound impact on our country at how we view young people. And much of the work I'm sharing this afternoon was shared with the Royal Commission and influenced some of their recommendations and decision. So as people will be aware, the incidence or cumulative incidence or prevalence of child sex abuse is really extraordinarily high. And fairly recent meta-analytic work shows that worldwide rates of abuse, and this is any child sex abuse in particular, range from about 8 to 31% for females, with a slightly lower rate, 3 to 17% for males. In Australian work, it's reflective of the international work, about 22% females, 8% males. If we look at more serious abuse, which is often measured by penetrative offenses, we see that the rates are lower, but still significant, a significantly high number. Now, of course, only a very small fraction of those victims make their way through the criminal justice system, and that's essentially the group I'm going to focus on in the discussion this afternoon. So over many years, we've had a program of research, again, started by Professor Mullen, to look at the child abuse. And it reflects the international literature that shows that there's a fairly good understanding about just how extensive child sexual abuse is. And we know quite a lot, particularly about short-term to medium-term effects of child sexual abuse. Less is known about the long-term consequences for a range of outcomes. And so the research shows, not surprisingly, a range of adverse outcomes for people who have had child sexual abuse or who are survivors or victims of child sexual abuse. So the aims of our program of research are fairly straightforward. It's really to investigate the outcomes of young people who were confirmed to have been sexually abused as children. And thus far, we've been investigating mental health utilization, psychopathology and use of psychiatric medication, suicide, fatal drug overdose, and we're very interested in the revictimization and also the offending relationships between child sexual abuse and offending. So our underlying methodology is fairly straightforward, and again, it's been built over many years now. In Victoria, traditionally, the Victorian Institute of Forensic Medicine, which is a sister organization to the one for which I work, has responsibility for providing the forensic medical work, and that included, until fairly recently, a unit which did assessments of children who were before the courts for child victimization. So they'd be assessed by forensic medical specialists who would make determinations about the nature of the abuse. And so our cases include the archival records of almost 2,759 children who were abused before the age of 17 years. The majority, about 2,200, are women, but it's also a very large sample of males. One of the things in the literature of child abuse, and particularly sexual abuse, is usually there's a significant underrepresentation of boys. So this database was initially compiled in the late 1990s, and we revised it and updated it about 2009, and have continued to develop and follow these people. So we have people from 1964 or who were whose abuse was substantiated between 1964 and 1995. So when the work was first started, over 20 years ago, they were mostly still children, but now most of our people, even the people who were the youngest in 1995, are now adults, at least on average about 35 years old. So we have been able to follow people up to 44 years in terms of their outcomes. And the database includes a range of abuse variables and demographic variables. Now, one thing that's a caveat about this work is because these, again, as I mentioned, the majority of young people who are abused never make their way into the legal system. The ones who do are typically ones who have more, who have abuse histories that are easier to prove in court. And I sit, for example, on a board in Victoria called the Therapeutic Treatment Board, and we have a treatment order for young people who engage in sexually abusive behavior. And many of the young people we see, if they don't have good evidence that the abuse occurred, often the police won't proceed. So what we find in our group is that we have a high rate of penetrative offenses. So it's about 63% of our group have, much more serious sexual offending than would typically be the case. Remember, in the general literature, penetrative offending for girls is about 7 to 12%. So this is a group that would have had more serious abuse than we usually see, at least as measured by sexual penetration. We then establish a comparison group, and one of the characteristics of Australia is that voting is mandatory, and that's actually very good for researchers because the voting register becomes a very useful repository to get a very good cross-section of the population. So we were able to develop a comparison or control group of people matched on gender and age within 2-year bands. And so we have a fairly robust comparison group that we can compare outcomes. And the people in the comparison group, of course, didn't have a recorded history of abuse. Now, what I'm going to speak about this afternoon is a range of outcomes, and I won't spend too much time on the methodology, but essentially what we do is through data linkage, we've linked the child abuse and control groups with a host of outcomes. I'm going to focus primarily on mental health outcomes this afternoon, and then revictimization and offending. But we've also linked them to, for example, the National Death Index. So we've been able to investigate death by adverse circumstances, including suicide and drug overdose. So in the first part of the work, we focus on these two data outcomes, and these are derived from, there's a public psychiatric database in Victoria, which has been in existence since the very early 1960s. And anyone who enters any aspect of public mental health gets recorded in that database. And then the victimization and offending comes from police contact as victims or offenders. And then more recently, we've been interrogating the public Medicare benefit scheme system in Australia. All Australians have access to public medicine through private practitioners, and we've been interrogating the Medicare benefit scheme and pharmaceutical benefit scheme for people. And there's been a slightly smaller population just because we weren't able to match records for all of the sample. So it's a slightly smaller sample, but similar in size and characteristic to the overall group. So what I'm going to really do is highlight some of the main findings as we go, and then I'm going to get to sort of the crux of some of the policy issues. So just if we look at the findings with respect to mental health utilization in the public system, what we find is that over the course of their lifetime to date, almost a quarter of people who have a child sex abuse history have been patients in the public mental health system. And that's a very, very high rate compared to the controls, which is about 7%. And we we love royal commissions in Australia. We also had a royal commission which ended just earlier this year. The report was submitted, and it found a very similar base rate of contact with the public mental health system. So we see that people with histories of child sex abuse have a much greater likelihood of having contact in some form with the public mental health system. And of course, we've looked more carefully at the form of contact and diagnoses. What we found is that exposure to child sexual abuse increases the risk for a host of mental illnesses, including psychosis and schizophrenia. I'll speak a bit to that in a moment. Affective illnesses, anxiety disorders, trauma disorders, substance use disorders, and of course, personality disorders. So we see a host of adverse outcomes. Now, one of the things that we have found in the course of our work that's been counterintuitive is that people who are sexually abused at older ages, and that is generally speaking 12 years and older, actually have far greater risk for development of psychopathology, and they have a greater usage of public and private mental health services. And of course, this is contrary to, for example, my early training working with children who are abused, where there was a belief that that younger children would actually have more adverse outcomes over the lifespan. But we have found in many of our studies, including the studies of going on to offending, that really the older children who are abused typically have worse outcomes. And I'll come back to that point a bit later in the discussion and reflect a bit on that. And also we have other findings that I'll talk about as we go with respect to gender and so forth. Now, I mentioned briefly schizophrenia. So when we look at psychosis and schizophrenia, what we find is that obviously the incidence is quite low, but so we're seeing a control incidence of about 1.4% for psychosis, and schizophrenia about 0.7, and that's essentially what we see in our base population in Victoria. But in the group of people who are the victimization group, we see essentially a doubling of those rates. So even something like schizophrenia has a higher base rate. Now, this is an interesting finding because the first papers that were published from this research, when the people were younger, didn't actually find a difference for schizophrenia. Differences emerged for the other higher prevalence disorders, but not schizophrenia. And the team at the time speculated that this is because schizophrenia is a more biologically based disorder. Therefore, you might not have differences in outcomes, in groups who will differ primarily because of the evidence of child sexual abuse. But the emerging evidence shows that there are elevations for the group who have been abused, even in schizophrenia. I mentioned around the age of examination. So when we look at schizophrenia, the people with schizophrenia, child sexual abuse and schizophrenia, on average were abused around 12.4 years. The people without schizophrenia, a few years younger. This is significant, although the standard deviations are quite large, so there's considerable overlap in the populations. So in most of our research, what we do is we actually look at the incidence of outcomes for the children post-12 and before 12. But for this one, it's just interesting that when we look at the age of examination, we found the significant difference. And that really caused us to investigate those age differences. Age remained significant, interestingly, even after controlling for gender, severity of abuse, and duration of abuse. So the severity outcomes I've already mentioned include penetration, but we also have data around duration of abuse. So age as a independent factor remains significant in modeling, even when we're controlling for other factors. Now, I'm just going to turn very briefly to the private mental health care utilization. And so in Australia, all people have access to publicly funded mental health care. The model here is that one has to visit a general practitioner and then get a referral to a specialist psychiatrist or to psychologists and some social workers, although not too many, there's not much uptake on the social work side. They have to be clinical social workers. So not surprisingly, perhaps, the highest usage rate is in the general practitioners. They are the gatekeepers. And again, you can see here that these are codes on in Medicare for mental health services. So people have a mental health plan prepared by the GP. So the incidence quite high, both for the CSA group, which is on the left, but also the general population has high rates of utilization of GP services for mental health. And I think that's a fairly universal phenomenon. We certainly see that here. Psychiatrists and psychologists and social workers also have significantly greater rates. So again, odds ratios ranging from about 1.3 up to close to 7, all significant from a statistical perspective. So we're seeing an increased utilization in public mental health and also in the private mental health sector. And then when we look at Medicaid, and again, the female CSA victims had the highest rate of services across those outcomes, so greater than males when we control for rate. Although the males are still elevated, it's the women who have the highest utilization. Now, this is a wall of numbers, but when we look at the numbers, essentially the medication dispensing for the broad range of psychiatric medication is significantly higher, again, in the abuse group as compared to the control group, and that cuts across different types of medication. And of course, many of you would be psychiatrists or medical practitioners and would know that you can't say that, for example, someone getting an antipsychotic is necessarily psychotic. It's indicated for a range of outcomes. But the point of this research is to show the differences in the control group and the child sex abuse group. And again, we're seeing differences across the group. So the utilization, again, probably parallels the prevalence of illnesses, with the mood disorders having the highest rate of medication, both in the control group and in the child sex abuse group. And I should say that, I should have said this earlier, that for the data we're looking at here with respect to the private mental health practitioners and the utilization of medication, this is a 5-year window between 2000 and 2005. So this isn't lifetime data. The data earlier around contact with mental health and diagnosis of schizophrenia, that's lifetime data. So it's just the way the databases work that we weren't able to get lifetime data for the Medicare and pharmaceutical benefit scheme data. So this is 5-year utilization. So interpret this as over 5 years, 21.5% of people who'd been sexually abused as a child received antidepressant or mood stabilizing medication, as compared to 13% of people in the control group. Now, just beginning to sort of wind down on the medical findings, and then I want to turn briefly to offending and revictimization findings. We see low rates of suicide and death by drug overdose, but the odds ratios are significantly different for people who had the histories of child sex abuse as compared to those who didn't. And remember, these are generally people up to middle age, so the rates of suicide in the population are very low, but the rate in the child sex abuse group is significantly greater than the population. And same if we look at fatal self-harm of suicide. And these are all determined by coroner's investigations. That's where these data come from. So when there's an unnatural death, it's investigated by a coroner, and they make a ruling as to the cause of death. And the risks were, again, higher for female victims than male victims. And this is significant because we know in the general population, rates of suicide are usually higher for men than women. But in the abuse group, we have the rates are in fact higher for female victims than male victims. Okay, and then finally, when we look at the contact, this is again, just overall, 80% of people in the suicide and fatal drug overdose group had contact with public mental health services. So these were generally a group of people who were already presenting for care. Half of them were diagnosed with an anxiety disorder, and the anxiety disorder diagnosis at the time included trauma disorders. This was a DSM 4 and 3 diagnoses. And then no differences occurred between the CSA victims who died and the remaining victims were found with respect to rates of affective or psychotic illnesses. It was really the broad anxiety disorders that had the highest rates. Now, I realize that's a barrage of information, so let me just summarize by saying we found higher rates of all forms of mental disorder and utilization of the public and private mental health systems, and we had, of course, higher rates of the utilization of relevant medication as well, and then adverse outcomes, including suicide and fatal drug deaths, were relatively low, but significantly higher in the case group than the control group. So I want to just begin to wind down by talking about the question of, is there a link between child sex abuse and later offending and victimization? And so I plan to speak for about 15 or up to 15 minutes roughly to get through this, depending on how it goes. I can go quicker or slower depending on the mood. So basically, in the literature, there has been significantly mixed findings around this. And so there's been posited that there's a possible link between child sex abuse and subsequent abusive behavior. And two main theories have emerged: the cycle of violence theory and intergenerational transmission of abuse theories. And these are theories that suggest that people who are victimized, including sexual victimization, progress to perpetrate abuse in adulthood. And it's the suggestion from the theories is that boy victims are more likely to become sex offenders than girl victims. And most of the support actually comes from retrospective studies relying on adult sex offenders providing their histories of abuse. And I should say that someone who's worked with sex offenders since about 1985, this is something that's changed over time. So in my memory, when I began working in the field, it was very rare for a person, including a sex offender, to admit to having been victimized. And of course, I was interested in that clinically because of my early work, but it was quite rare. So we've seen an increase, and this has been reported in the literature, and it's probably for two reasons. One is there's a greater, I think, acceptance that people are abused, and there's probably less stigma attached to that. But also, we know that in sentencing models around the world, there's mitigation afforded to people who have adverse histories. And so there's some speculation that this rise in reporting may actually be an artifact of the system. So the study we conducted is very important because we actually aren't relying on retrospective methodologies. And again, most of the work has been retrospective methodologies where both the child sex abuse has been unsubstantiated and there's issues around recall bias and, again, motivating factors to distort the truth under circumstances. And reporting bias in offender populations, again, is particularly concerning for the reasons that I just talked about. And therefore, retrospective studies may potentially produce a high rate of false positive results. So in the literature where sex offenders are interviewed about this, rates vary, but in some studies, it's been as high as 75%. So extraordinarily high rates reported. So when we looked at this database, again, looking at the criminal outcomes over lifetime, what we found is just right at the very beginning, when we looked at any contact with police, and this is for any reason, and so in Victoria, I should be really clear that what happens whenever the police make contact with an individual, that's recorded. So if the police interview someone who has been victimized or even witnesses an event, that's recorded in the criminal database to which we have access. So this is any contact at all. And you can see that, generally speaking, there's a small but significant difference between cases and community. But we see those differences become much more dramatic when we look at criminal history versus just general contact. So this is having a history of a charge or conviction for an offense, we're seeing almost a quarter of the cases, male and female, having that history, as compared to about 6% of the community group. Now, when we break down the type of offending, we see differences across offense types. And of course, some of the offenses like homicide, exceedingly rare. So you couldn't make anything of these numbers because they're too small really to warrant comparison. But if we look at sexual offending, violent offending, and so on and so forth, we have elevated rates of outcomes, again, for people with a history of victimization. And the odds ratios are again significant. And the numbers, again, are relatively small, but certainly much higher than you'd expect. So sexual offending, and I'll come back to this a bit later, is one area that has some significant difference, which we interrogate a bit further. So as you can see, the offenses which are more personal injury offending typically have the higher rates of outcomes. Now, when we look at sexual offenses in particular, again, the problem is even with a very large sample, we have exceedingly small numbers. So when we look at males, again, of the roughly 500 men in the sample, or people who were abused as boys who are now men, about 5% of the people went on to have a conviction for a sexual offense, as compared to 4 people, or 0.6% in the community. And for females, it's obviously even smaller, and no one in the community. We expanded a bit to include prostitution offenses, not that they are in any way sexual offenses, but they're offenses that have in common the sexual element. So we did see, again, no people in the control groups having prosecuted for those offenses, but in fact a pretty high rate of women. Again, out of about 2,200 women, 32 or 1.5% went on to have a conviction for a prostitution offense over the lifetime. And for males, a very, very small number, but again, no one on the control side. We then, again, this is very busy and I apologize, this divides the group by males and females, and it looks at early versus late abuse. So there's a few things I want to draw your attention to. The first thing is, again, if we just look at the males and sexual offending, we see the males who are abused at 12 years or above, we see about 9.2% go on to have a sexual offense. So that's now becoming a significant number, that is 9.2%, as compared to about 3% who are abused less than 12 years. And similarly, when we look at any offending, the only group that has the majority of people offending is, in fact, the people who are males sexually abused at age 12 and above, of whom more than half had some criminal offense over their lifetime. So I think that's quite remarkable if you think about that this is significantly different from the control group, and significantly different from the younger boys. And for girls, the rates are elevated, again, compared to controls, but they're still relatively small numbers. So 1 out of 5 girls who was abused at age 12 or above ends up attracting an offense over the lifespan, but compared to more than half of the people who were abused who are males. And again, we'll come back to the age phenomenon in the end. So when we just summarize the sexual offending outcomes, what we see is that for the child sex abuse victims, 12 years and above, 9.2% versus 0.6. So it's something like 1 out of 11 in the child sex abuse group, compared to about 167, 1 out of 167 in the population. So a significantly elevated rate. But of course, the vast majority don't have any sexual offending. So that's really important. And I know in the work I do, quite often interacting with people who are victims or or family members of victims, they're quite concerned, will my child turn out to have these problems? And we can say that the majority won't. Now, the final topic is just revictimization. And so, again, a wall of numbers, hard to see probably on your screen. So what I'll do is, again, I'll highlight the more important findings. So when we look at the revictimization, what we find generally is that the odds ratios now are actually relatively small. For any contact as a victim, the cases have about 36.2% versus community. So it's a very small difference, and it's significant just because it's a large number in the sample. But it's basically a third to about 36%. But when we look at victimization, revictimization for sexual assault, we actually see now the differences become more significant. So the revictimization for the child sexual abuse group is about 8%. And for the community, this isn't revictimization, this is victimization. So it's about 1.6%. And again, other areas, we see similar elevations, although the odds ratios are much smaller. The most profound difference really is in the sexual assault difference, and also areas like stalking and violence are significant. Deception wasn't, and theft was, but only a very, very small difference. Now, again, we divided the sample by age and gender. Oh, sorry, this is the violence number, and then divided the sample by age and by gender here, and we've got outcomes for males and females. And when we look at sexual outcomes again for males, we see a similar sort of finding that it's very, very rare to have anyone in the comparison group be victimized sexually. It's again rare, 30 out of 500 in the cases group, but the percent is about 5% compared to less than 1% with an odds ratio of about 7.01. So that's a significant difference. And similarly, when we look at sexual victimization among females, again, that's significant as well. And incidentally, the odds ratio is slightly higher for the males than the females, but significant for both groups. That's the main finding to highlight from that study. So what I like to do in the remaining few minutes is really just highlight some of the conclusions. So when we look at the combination of perpetration and being a victim, we find that a quarter of the CSA survivors or victims proceeded to have a history of both reoffending and revictimization, so 1 out of 4, compared to fewer than 1 out of 20 of the people in the comparison group. So again, we see a significant difference, just as we saw with psychopathology and mental health service utilization. We see significant differences in the victimization and offense data as well. Now, there's a host of sort of conclusions and cautions. So the starting point has to be resilience. So I think one of the more remarkable findings is that the majority of the victims do not become mentally ill. That is, they don't present for public mental health or private mental health care. They don't evidence substance abuse problems. They don't commit suicide or die by drug overdose. They don't become offenders, except again, boys 12 and older are slightly more likely to become offenders. More than 50% become offenders or victims of crime. And in fact, if we put the numbers together, about 75% of children who were abused did not have any of the adverse outcomes, although about 25% did. And that, I think, is an important finding, because I think we live in a time when everybody assumes that an adverse event in one's life will produce adverse outcomes, and that's just not the case, thankfully. Tragically, though, we do see relative risks across the domains that we've looked at this afternoon. That includes, as we talked about, psychopathology, death by suicide, death by drug overdose, offending, including sex offending, and being victims of crime, including particularly violent crime. So there is evidence that child sex abuse can be a substantial risk factor for these outcomes. And also in this contemporary research, and some other researchers have recently had similar findings, there's associations now with psychotic illness, including schizophrenia, and an increased risk for suicide and fatal overdose. So there are a range of implications for those of us who work in mental health systems and offending systems, and that is we need to assess disorders commonly associated with trauma, but not exclusively. So it's certainly the case in our work, and that's probably one of the early surprises, is that we saw higher rates of mental illness and utilization of services for a range of different disorders, not just trauma. And of course, again, and I don't know anything about what's happening in Scotland at the moment, but the trauma narrative is very, very strong here, and it almost takes over the narrative when we're seeing difficulties in a host of areas. And also, one of the profound findings was that it's the children abused later in life and more severely who have the highest risk of adverse outcomes. And we find that almost across the board. The area where we don't see it quite as strong is with revictimization. The age finding isn't as robust with revictimization, but it is with all other forms of the outcomes that we've looked at. And why we believe that is, and we are doing some research moving forward trying to investigate some of these things using different methodology, is that from a psychological perspective, obviously, and remember, this holds for severity and duration as well. So even if you have a younger child who on average has penetrative offending over a longer period, they'll be less adversely affected than an older child. And we think the reason is that obviously for younger children, they don't have a cognitive frame of what the invasion of the body is from the sexual abuse, whether it's penetrative or otherwise. But we know that with children in particular, in the prepubescent years through pubescence, the body shame, the embarrassment of the body and so forth, that they have not only any potential physical damage, but of course psychological scars from the victimization as well. And working with victims, this is what you often hear for victims who've been sexually abused. Like, for example, entering a relationship, how soon do you tell your new partner that you've been a victim of sexual abuse? Do you tell them early and risk disclosing, or do you tell them late and then they ask, well, why didn't you trust them earlier? So we believe there's a disruption in self-identity and in the capacity in forming probably protective relationships. So that the age finding, I think, is quite profound. The people who assess and treat people at risk for offending, including offenders themselves, of course, this is a pretty important finding, and I think particularly the boys who are in the older group. And I should say that we're looking at sexual abuse specifically, but there's other data that look at other forms of abuse as well, with similar sorts of findings, although not as strong in some of the areas as we've found. So we think that the sex abuse has some profound outcomes, but that doesn't reduce the outcome difficulties for people with other forms of abuse. And in this research, we weren't able to tease out, because doubtless some of these people would have probably had co-occurring forms of physical abuse. And indeed, some people in the control group would have doubtless similarly had abuse. But we see these people as having increased risk for offending, and again, typically later in life, and that relationship to sexual offending. So we think that work that's being done with children who present with sexual offending when they are older, have been abused older, and by older I mean still young, but older than 12, there does need to be preventative work around healthy relationships, and not just looking at again, a focus on trauma and the damage that they may have ensued. And then finally, we obviously need to pay attention to whether the accused was sexually victimized when we are working with sex offenders, and try to determine whether there is such a relationship and how that might affect things as treatment. And then finally, we need to strengthen, of course, the commitment of resources, both human and capital, to victims of child sex abuse. That continues to be a problem, I think, internationally. And I'm always disappointed in how few resources really are dedicated to child victims in the different systems in which we work. And obviously, criminal and other legal solutions are relatively futile in improving the situation when they become adults. So it's much better to try to intervene when they're young. So I've gone a bit over what I expected, but they're the end of my remarks. And this is where I holiday each January. So that's where I spend my Januaries, looking at that beautiful, which reminds me a lot of Calgary Bay, as I showed in the picture at the beginning. So maybe this place could be renamed Calgary Bay as well. So thanks very much. And as I mentioned, I'm happy if there are any comments or questions.